that's me whistle top tour about cancer care reviews. I'm going to hand you over to Charlotte now, who I will let introduce herself. Thank you, Charlotte.
Hi there, everybody. Hi, I'm Charlotte, and I'm a Macmillan Neurology Nurse Specialist at Ipswich Hospital. So my role as key worker, I provide specialist information and support to patients with a diagnosis of cancer under the urology team at Ipswich Hospital. And one of the reasons I'm on the project team is because one of the pilot sites is urology. Another aspect of my role is to facilitate access to supportive care. We're incredibly lucky within SNF to have our amazing cancer information centres, but we also do things around H&A's care plans, health and wellbeing events, so it all fits in wherever you are in the care system. It's important to discuss personalised care. So I've been asked to look at the wider picture with regards to personalised care. Next slide, please, Martin. So I just want to make sure we're on the same page in terms of what we mean by the different sectors of care that our patients will experience. So primary care is the first contact for patients in the UK. That is different elsewhere, as we know, particularly America. You can access directly either as the individual or the family or the carers. We commonly associate primary care with general practice, but we also need to think about teams such as community pharmacists, dentists, opticians, and a couple of other teams I'd add in from these slides would be the local healthcare team. I've actually referred 3 patients this week for physionoti in the community, and also the navigator roles that you'll all be very familiar with in primary care. We also have them in secondary care as well, and they're making a huge difference to patients. Secondary care, you can only access secondary care as a patient if you're attending A&E, which obviously none of us really want to have to do. It's an emergency setting. Unfortunately, there are patients presenting late with cancer, partly as a result of the pandemic. But ideally, we would be looking at planned care, by which we mean a patient engaging with their GP or advanced nurse practitioner in the surgery and having a referral into secondary care. So certainly in terms of my speciality, that might be for waterworks or LUTS problems in a benign setting, or for raised PSA in a suspected prostate cancer setting. We have to remember that whilst patients may have referrals, say, into urology or gynae as the other pilot site, they might have a number of referrals going on at the same time. So already we've gone from the umbrella of primary care and we're going off in different directions into secondary care. Those referrals are disease specific, and that's quite a big thing for us to remember. So the teams looking after patients will be speciality based, whereas certainly in primary care, patients are cared for with regards to all their conditions. I say, again, a bit like an umbrella of care. Things are improving in secondary care, so locations do include community settings, not just hospital-based care. Very much it's about understanding what patients need. COVID has helped in terms of technology, and also about us being a bit more flexible. So, for example, there are outreach chemotherapy clinics now in community settings. Consultants and nurse practitioners will do clinics in health centres from secondary care. And we certainly have places like libraries who are offering certain types of Macmillan support. We do need to mention tertiary care. Our patients do access tertiary care generally through us in secondary care, but you can direct refer from primary care for the more rare types of conditions. These are highly specialised conditions requiring, for example, complex cancer surgery, and certainly in our area within East Suffolk and North Essex, and also within Mid and South Essex, those tertiary centres would be Southend, Broomfield, Norwich, Addenbrooks. Essentially, that's yet another layer of complexity in the care system, but it's the same patient and the same condition. So communication and partnership is absolutely key. Next slide, please, Martin. So what are patients telling us about how well we're doing in terms of working and joined up and providing personalised care? We've obviously heard that incredibly powerful feedback from Lee, Marion and Fiona, and I think that mind map is an amazing way of actually sharing those thoughts with other patients and clinicians. So thank you very much to all of them for sharing their experiences. We also, as primary, secondary and tertiary care, get feedback through the National Cancer Patient Experience Survey, and anyone can access those results through the NCPES website. You can search by hospital trust, and it looks at primary care referring into secondary care, links with tertiary care and back to primary care. It's a quite useful tool. A little bit of self-selection with patients, but they are working on trying to reach more vulnerable and excluded groups in terms of ethnicity, language, migrant status, people who are homeless, to get a bit of a wider view. But when we look at the 2019 survey nationally, 73% of patients felt that people work well together within the care systems. And whilst that's a great way to start, unfortunately, that means that 1 in 4 patients didn't have an experience that meant that we all worked well together. So I think that's a real motivator for everybody. As providers in primary and secondary and tertiary care, we also link in with charities, so an NHS England. And Macmillan obviously do a huge amount of work in terms of advocacy and research, and NHS England very much oversee a lot of the research data and surveys going on. So one of the things that's already been mentioned is about understanding cancer for some, not all patients, as a long-term condition, of which they may have others. And actually those other conditions can seriously impact on what we can do for cancer for our patients. So if they have very severe COPD, that might mean an operation would be very risky, even though that would be the option of choice. So it is about looking at the person as a whole person, and also taking the knowledge and experience from other pathways, where say COPD or asthma, there's very good pathways in terms of primary care support and longevity in that care. Macmillan did some research with patients, and I think quite a good visual picture is looking at cancer as a jigsaw, with all the different care sectors coming together with regards to supporting and caring for that patient. The slide before really probably should have added things like social care, mental health services, and obviously Lee mentioned end of life care as well. So we are a package that comes together, but we are bits that sort of need to knit together and work in partnership. So quite a useful imagery there. Already mentioned some vulnerable and excluded groups. So a project like this would need to consider how we can diversify and certainly get to patients where English might not be their first language, who may or not have a home address. So that's work that's ongoing in a number of sectors. I think just going back to the top, some of those are free text comments from the national survey in 2019, and they do reflect a lot of what's been said already about this feeling stuck or feeling left in the dark, often when you're transferring between care providers. On the positive side, though, I think, it's important to acknowledge that there is a lot of, recognition for kindness, time and care, and people saying thank you for what's being done within the health service. Next slide, please. So what might a best practice interface look like? How might we get to that seamless coordinated care between care sectors where the patient's at the heart of all that we can do? This really applies to anything, not just this project and personalised care, and very much the graphic is about flow, direction of flow. So good communication, collaboration, relationships, that's for all of us, that's patients and health professionals or social care professionals, embracing innovation, which this project is doing through the use of VCCR, that virtual medium, and also really, really key, having clinical champions. So for us, that might look like, Pete and Liz, myself in secondary care, and Emma at MSc, but also the non-clinical champions, so our patients or volunteers, are actually more important than anybody else. So having those drivers, having people invested is really important. I think a couple of things that probably could be added to that are good documentation, and also developments such as patient portal, and Fiona very much has talked to us about MyChart, which is a tool at Addenbrooke's for patients to have access to and ultimately ownership in the future of their notes. And also Southampton have a very good patient-facing electronic notes record that would be worth a look at, and they were a big researcher for the personalised care follow-up project. So there's a lot of innovation going on. COVID has, as part of the silver lining, really encouraged us to look at other ways of working and to be flexible. So what are we trying to achieve through our best practice and our interface and personalised care? Ultimately, it's improving quality, safety and the patient experience. Alongside that, I think we have to remember the professionals in this. Our patients are categorically number one, but actually need to have good staff, trained staff who are able to provide that level of support and have support themselves. So increasing job satisfaction, using NHS resource wisely, and actually having these highly trained, motivated people, as Pete mentioned, will actually feed back into patient care and hopefully, provide some, continuity for patients, and try and avoid some of the gaps that Liz mentioned in terms of staffing and perhaps well-being as well. Next slide, please. So Liz has talked a bit about the practicalities of personalised care, and this is really about the philosophy or direction of travel. And the graphic is on purpose because it's very much about signalling partnership. I think it's about signalling momentum and continuity and all being in this together. So shared decision making, empowerment, partnership. So personalised care is a way of us looking at this new relationship between people, professionals, and this is for all conditions, but we're focusing on cancer at the moment. And it's about patients having an active and empowered role in the way their care is planned, and that's truly doing that. Certainly one of the things that people are now looking at are personal healthcare budgets for health and social care in terms of direct and indirect payments. So there is actually evidence and work out there to properly implement this active and empowered role for patients. Secondly, it is about what matters to people. And this is the key to the H&A and then the cancer care review or the care plan in secondary care. It's about what for that person are their strengths, which is important to identify, and also what are their needs. It's a change in culture from quite a medical model to a patient-led model, and that will take time, and we need our patient champions along for that. It's about self-management, which is where personalised care follow-up comes in. Well-being is really important, shared decision-making, the digital infrastructure that we've spoken about, and also having a lot of support base in the community, not in the acute care sector. So when we look at the interface with personalised care, we're saying all care providers in that jigsaw that Macmillan described need to truly embed personalised care and work together with patients, because that is the only way we're going to deliver high quality, timely, accessible care for patients. Next slide, please. So just in summary, I've just talked a bit about what do we mean by the primary and secondary care interface. So we all know the sectors involved in providing care to patients and where patients move between, and that's not necessarily a linear flow. So patients may move to and from, and it's really important that we communicate together. What do we think best practice looks like? And this project is one of those initiatives to try and drive best practice forward. The patient voice is the most important in all of this because we have to be driven by our patients and the community that we serve. We're also looking at personalised care within cancer care, but actually applies to all types of care. The big things are patient, family, community are at the heart of everything that we do. We do need the tools to be able to do that, and VCCRs are one of those tools, but very much, this is a learning experience for all of us, but I think the direction of travel is a very positive one. So thank you very much for your time.
Thank you very much, Charlotte. And I should have said at the beginning as well, as a project that's had a huge amount of patient involvement. We've also involved secondary care from the outset, and I think any piece of effective clinical transformation that I've ever been involved with, it depends on primary and secondary care working together, and I think this is one of the effects of the pandemic that's perhaps not well recognised, is that primary and secondary care relationships are probably at the lowest ebb they've been for decades, which I think is a huge, not only a huge shame, but a huge problem. But hopefully in this project we'll take some steps to heal that, and also we'll have secondary care nurses actually in the group consultations to actually promote that communication. As we've hinted, a huge part of this, and one of the things we hope the project is going to achieve, is to leave a legacy of more specialised training in practice nurses within the east of England. And Lisa, who has been the driver from this project from the outset, is going to talk about the training and support package available, and then she'll hand back to Lee, who you heard from at the very beginning, because one of the innovative approaches we've actually used an innovative approach to evaluation, and that touches I think on something that Claire Browning raised in the chat about to develop a document that explores all the different models being used for cancer care reviews, and this project is going to be fully evaluated, and that hopefully will be one of the outputs of it. So first of all, Lisa, and then we'll lead on to Lee, and then we'll have questions at the end.
Thanks.